one of the things that I think that is interesting about your background is the fact that you are also boarded in lifestyle.
That's right.
Yeah. And, when we were having E2M with us and they were talking about getting people together, having people have lifestyle changes and, building those relationships and how they are a part of a person's recovery. And if we look at the Vet Wellness Village and putting people together where we're looking at new ways to treat, I'm curious just, where you think that might fit in the paradigm.
Well, I think when we think about just pain in general, and particularly in my field of musculoskeletal medicine, you have to think about the whole patient throughout the process, because pain is not just an episodic problem. And when you look at it from that perspective, you'll see that the literally hundreds of factors that play a role, whether in some of the work that you're doing to analyze the additional effects of anxiety, mental stress, and things like that, or balancing one's own personal nutritional aspects. All play a role in some way of feeling somatic pain, nociceptive pain, or other aspects that can contribute to the pain syndrome. Mm-hmm. For me, it's fairly straightforward in my field, because when you are in pain from a broken bone or from pain from arthritis, it becomes something that you can isolate and try to fix, which leads us to solutions that are only identified as a kind of a specific solution for a specific problem.
Right.
I think the world is moving toward a greater sense that that rather than one instrument in an orchestra to play the music, we have to look at the whole symphony, the whole orchestra to play the symphony.
Yes.
And so that can include things like regenerative medicine. It can include things like mental stress awareness, holistic aspects from learning from just ancient medicines, and then ultimately changing aspects of your lifestyle that'll affect, I think, one's own individual health for the long.
Yeah, I couldn't agree more. And I think that that's something that we've seen with, being able to measure the biopsychosocial components of pain with what we do, and being able to see that there are, like you said, the cognitive aspects of it, as well as the social aspects, as well as the physical. And, one of the examples, like a total knee arthroplasty, for example, great. Yeah. For many, many people. And then there's a lot of data that looks at the pre-existing, anxiety, for example, mm-hmm. Being a factor that can play a role in the outcome.
Yeah. And so I think as we look at the economic models around things like you mentioned, total knee arthroplasty, which I'll talk about in a minute, the economic model around that is traditionally been episodic or fee-for-service based, meaning right. If I have a problem in my knee and I get a surgery, I'll get paid for it and we'll take care of the problem.
Right.
But when you think about it in the context of value, right, we always think about it as what investment can I make in a particular episode, non-episode, or something like that, that ultimately plays a role in creating a better outcome for the long term. Mm-hmm. So, in some of the models we're creating is it worth the investment to do more on the front end of some of these things in order to potentially prevent a longer term negative outcome. And so that's where we take into aspects things about wellness and what are the values of these things in terms of the larger condition of osteoarthritis rather than the episode of a total knee arthroplasty.
Absolutely, right. And so, even if we look at, for instance, the analgesic protocols that we've seen updated over the years, we utilize ketamine, for example, as a way to protect the central nervous system from any kind of nociceptive barrage during a surgical mm-hmm. intervention. Or, there's even been discussions about using cognitive therapy in advance of a surgical intervention to be able to prepare a person that has anxiety and taking that anxiety down so there's not wind up in the central nervous system mm-hmm. that can have an effect on the outcome. And I think that you are using virtual reality.
Yep. Yeah. So, on the cutting edge of some of the way we treat pain, musculoskeletal pain, are things like addressing, aspects of distraction therapy, meaning how much does the mind play a role in mitigating actual somatic pain. They emerge from surgery wearing virtual reality goggles.
Right.
And these goggles will allow them to go through a series of breathing exercises in order to literally take their mind off of what's happening. But this is all part of a larger picture of addressing pain, whether it's through traditional methods of opioids or non-opioids or analgesics or injections, to recognizing the input of your mental state as part of the mitigating factors.
Yeah, absolutely. And again, it just all kind of goes into that biopsychosocial aspect.
Well, in keeping with some of the conversation we had earlier about this move toward value-based care and knee surgery, I think one of the key components of this is really looking at where we are today, our current state of the art, and then trying to reimagine or rethink about how we might reimagine the knee surgical episode for the future.
Yeah.
And so this slide here is really just to identify and share with the audience, our current methodology when we take somebody who has knee pain and we decide that they want to or they should have surgery. Well, CMS and all the government insurance regulators, et cetera, require us to go through a certain number of steps to say you failed a certain amount of therapy or a certain amount of conservative care before you get indicated for a total knee replacement. Mm-hmm. And it's pretty universal in the United States, and it's all designed in order to help allow for patients to have tried something in conservative care. And largely this is related to the evaluation and treatment of knee pain. And so you can see here in this image here, the colored boxes are really the only things that are required from the standpoint of conservative care. The problem with the way we currently diagnose knee arthritis, and we're talking about the total knee arthroplasty episode, is the problem with the way we currently do it is we only do it off of static X-ray. And so our diagnostic problem is the fact that we actually don't know how patients who have bad X-rays can actually function because many patients who have bad knees actually do pretty well. Mm-hmm. So pain is a mitigating factor, but it's very subjective at the same time. So it's difficult to say just purely based on an X-ray whether or not somebody has to have a total knee arthroplasty. These are two images, one on the left, one on the right, that shows two different versions of a patient's knee. One that shows bone-on-bone disease, but it might surprise you to know that the one on the right that looks the worst is actually someone who's doing the best. So pain is very subjective. And so when we look at the different modalities that we have incorporated at our institution and others, I had mentioned earlier that the treatment of knee pain with ultimately a surgical solution at the end can involve a number of different modalities on the front end in order to try to alleviate the condition and potentially avoid surgery. And so for us, these are just some company names that we work with in order to try to address that. Rome is a company that was developing a robotic assistive device for patients with large knees or patients who are not qualified for surgery but can still have knee pain. Mm-hmm. Icarus is a bracing company that we use that alleviates the anterior knee pain from getting up from a sitting position. Mm-hmm. Harvard MedTech is a company that we use in the world of virtual reality to really address the mental components of these disease. And so as we go into some of these things, this is one company that we work with. It's called KG or Imovi. And this is a company that for the first time, we've been able to actually identify the biomechanics in an in-office setting of how a knee actually functions in a person. So a person who has a really bad X-ray could actually walk very well. And part of that reason is because when we actually get involved with the patient, you can actually see their knee in 6 degrees of freedom. Mm-hmm. This allows us to tailor a physical therapy prescription as opposed to just using a routine form that says do this, do that, which is not universal for everybody. Mm-hmm. And this is one way we can mitigate the pain and also avoid potential surgery. But that's just one piece of a number of things. We had the pain. Mm-hmm. We use things like virtual reality, which takes this distraction therapy to a new level, right? Mm-hmm. As well as other things that can affect your mind-body balance. And then when you look at the results that we've seen, just from some of the things we've done in virtual reality, we've seen massive reductions in postoperative pain in patients who have had knee surgery. To 40% of patients report reductions in pain. 72% have shown changes in their behavioral health impairments, and 115% of these patients report improved sleep architecture, which means that I'm not waking up in the middle of the night from pain. And so if you take that as an individual item, and then you say, I've got a whole constellation of other things, there is a world that's possible where we can actually potentially have a situation where we're doing surgery and can offer it in a painless way.
Yeah.
So is it possible ultimately to have a painless surgery? I think it is.
I
These are
agree.
another examples of some of the biomechanical changes, whether it's knee bracing. The one on the left is actually a robotic portable device, which takes the load off the knee. And so when you ask patients who have knee osteoarthritis and they're not qualified as an ideal patient in the world of kind of this value-based mindset where we're trying to improve outcomes, you take a patient who perhaps has a high BMI and we know that their surgical outcome might be negatively affected.
Right.
Our choice right now is to say you must suffer and try to lose weight, when now we can potentially provide some assistive devices that actually can help them function and get off that cycle of impairment. Because when you're large and not being able to move, the worst thing you want to do is be told that you have to move more.
Right. Absolutely.
And so these things are very silly.
Game changers.
Game changers. And I know we've already talked in a number of these different opportunities, talk about the world of orthobiologics. And this, I think, is a new frontier for us as well. It's untapped. I think the evidence is still coming, but certainly the patient reported when it works for patients, it's dramatic. But identifying exactly which patient is going to work for, I think, is the next step, so that we can titrate, whether it's DNA analysis or other some sort of phenotype that matches the successful outcome. The closer we get to identifying who's going to be the best patient, where we can closer to almost saying we know what your outcome will be, it's going to change the world of how we approach orthobiologics.
I agree.
I think the other aspect in the spectrum of managing the whole episode is remote therapeutic monitoring, because oftentimes when patients come in for surgery, they come in and they'll see the doctor at 2 weeks or 6 weeks or another 3 months after the episode, at which time you're only getting a snapshot of what's actually happened. And when that occurs, you have to be able to try to understand what's happening in between. And remote therapeutic monitoring allows us to know whether the patient has actually done their exercise at week 4.
Right.
Are they participating in the recovery?
Absolutely.
And it gives us a better sense of their potential ultimate outcome. Just to give you a final sense of what the traditional approach, that first slide that I showed about the traditional things you have to check off. With our traditional approach, you have a certain cost that's associated with it. And you can see it's actually really debilitating and uncomfortable for the patient, because they'll see a primary care doctor, be referred for an x-ray, see an orthopedic surgeon, be referred for some physical therapy, and really a very disjointed approach of care. And when you get to that, it costs a certain amount of not just dollars, but a certain amount of opportunity cost for the patient. So rejiggering our approach to make it patient-centered is one thing. The second is to then look at that total cost and say, can we reduce the ultimate total cost by adding things on the front end that will increase the value and decrease the cost at the end, avoid surgery, for example.
Absolutely.
And even within our traditional approach, 43% of patients express dissatisfaction with how their total knee episode has been managed. Right. And so at the end of the day, by adding all of these things into a new series of offerings that we put on the front end before knee surgery, we can actually, we can actually approach knee osteoarthritis as a condition. And this is the talk we're beginning to investigate, to create what's called a condition-based bundle. One price, all things included, avoid surgery, and if surgery is included, is being done, then that's included in the total price as well.
Absolutely.
And I think when we do that, we can actually play a role in potentially controlling costs and guaranteeing outcomes.
Yep.
And so, finally, what I would say is when we get there, right? The future as to when we get there is actually not that far off from where we are.
Right. And I agree 100%. If you go back to that last slide where you were, I agree. And I think that what we have is potentially the ability to, it's the data, right? Yeah. So in this coming spring, I've been asked to speak about medical device data. And when you were talking about taking osteoarthritis, for instance, or knee arthritis, and creating a bundle around it, I'm curious what your thoughts are about introducing individual biosignals, like pain trace. Like I'm gonna go there, and being able to actually have that become more of a consumer or a consumer accessible
Sure.
piece of data. And so then when you're working together with that level of data, you have the ability to, I think, look at that bundle and be able to come in preemptively, utilize modes of care that may be appropriate for that level of pain, that level of damage. And then throughout the progression of the disease state, you can look at prescriptive analytics that allow you to not only tailor personally because you're looking at personal biosignals, but you're also looking at what has worked on a larger scale. And I think kind of roll that all up into the value-based care that you're talking about.
Yeah, I think when I was talking earlier about using new gait analysis equipment in order to understand what exactly we're treating, it's all part of this this concept of saying, do we know what we're doing, right? And asking really three questions. You know, are you any good? Meaning, are you good at what you do? Are you getting better? And then the most important question is, how do you know? And when you can't answer all three pretty definitively, then you've got to find additional tools that will already help you get there. So pain trace, other things that can really break through this barrier of subjective pain and identifying objective markers that then tell us whether or not we've actually alleviated those markers is really part of it. So
what's the delta?
Exactly. And so I think that's part of this new, what I would imagine will become a new version of how we approach patients who have osteoarthritis, knee pain associated with that, that will ultimately be able to empower us to say, you're the right patient. We know exactly what's going on. Here's what we're going to do. And then I'm going to look back and say, did we actually achieve what we said we were going to? And I think in medicine today, we don't have a whole lot of that.
And that is exactly where we are going.
Yeah.
and that's why I always enjoy talking with you because I go, yep.
Well, that's good.
It's never a no.
It's good to know. So, but thanks, Deb. I appreciate the time, and hope the audience gets something out of this.
I hope so too. I really appreciate your time too.
Great.
Talk to you
Thanks.
soon.
Okay.
Yeah, thanks, Mike.